Good afternoon, everyone. 2:15. We're just about to get going. All right, guys, thank you everybody for coming. It's 2:16. We're going to call the June REMAC meeting to order. We'll start with the Pledge of Allegiance, salute to the flag, and then a brief moment of silence. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Please remain standing for a moment of silence. Thank you very much. So I was just taking a look at the people coming in. We have a voting quorum, which is good. We have at least 9 voting members present. Just as always, point of order, this is a public meeting. We're required to hold it in person, but we have a telecast for web viewing only. Attendance is not taken from those who are viewing, only from those who are here present and signing in. I received excuses for this meeting from Dr. Kurt Dishner, paramedic Paul Diver, Dr. Caitlin Keenan, Dr. Stephen Mulbauer, Dr. Bramonti, Dr. Ting, Dr. Singh, paramedic Capsadero, and Todd Haken. So those meetings came with letters, so they were excused. Moving on, there were 2 corrections I received by email for the minutes and attendance. The first was that the attendance sheet sent out indicating presence or absence from the last meeting on the non-voting sheet had the incorrect date, so that'll be corrected to the April 3rd date as opposed to December 13th. And that the next correction was on the agenda. At the bottom of the agenda, it had the incorrect next meeting date. The next meeting date is not in July, but August 7th. It'll be held at this facility at 2:15 p.m. Okay, given the corrections, I need a motion to approve the last meeting's minutes and attendance. Dr. Zazo, Shearson. Anybody opposed to that? Okay, great, thank you. All right, incoming correspondence, our usual and customary from the State Bureau of EMS. We only received 1 compliance notification. Nicholas Messina from Yonkers, New York, EMT 506368. His card was surrendered effective 4/15/24 for violations of Part 800.16 A7 and 13. I received a request to make a presentation from Live On New York. They here?
I am.
Oh, yeah, great, thank you. So at the conclusion of formal business, we'll have you guys make your presentation. Live On New York is trying to help the pre-hospital staff understand what it is that they do so that we can improve, I guess, organ procurement and how best to care for our patients and just make you situationally aware. I received an email request with the appropriate documentation from Rockville Center Fire Department requesting Dr. Neil Kirshen to be a field physician, which will be voted on under new business. Received an email request with the appropriate documentation and New York State forms from Williston Park with a change of medical director from Dr. Ng to Dr. Zito. That'll be also brought under, new business. I apologize that that wasn't put on the initial agenda. There was no significant outgoing emails. With reports to, committees, for myself, welcome to our new members. And otherwise, no significant, report on the chairman's end. So that's good news, I guess. With regards to CMAC, just moving along, so this way maybe we can get out of here quick. There was a discussion at the New York State level regarding the use of naloxone and nalmefene. There's a police agency that's using nalmefene. New York State said, after discussion of both the medical standards and then at the CMAC, the only pre-hospital approved opiate antagonist is naloxone, not nalmefene. So that if you see an agency that wants to get nalmefene, you have to tell them it's not approved, it's not available for them to use without a specific physician order for a particular patient. It's not under the general opiate overdose protocols or policies within New York State. Let's see, there was a discussion about significant improvements on ambulance inspections at the state level. They were talking about how they look at everything on the ambulance. So just let your EMS providers and managers know that they're even looking at suction canisters and that the suction canisters expire. This is what Ed Maker said at the state level. Okay, so yeah, there's also an updated policy on blood glucose and fee waivers, a policy on albuterol that came out. MOLS training is out as the law changed. I think that's important for you to get your providers to pay attention to. If a patient signs their own MOLS and DNR, it can't be rescinded by the family. That's the new regulation. It used to be that if once you were unconscious, you no longer had capacity. Your family can make decisions if they were your healthcare proxy. Now the regulation states if you signed your MOLS and you had capacity when you did it, that MOLS is that's your wish, and it doesn't change. So for EMSC, EMS for Children, there was that emspetsready.org website that EMS agencies were encouraged to access to perform an assessment of your agency's pediatric readiness. I hope some of you did it. Let's see. I'll let Don talk about education. From Ryan, there was, just remember, we're switching over to NEMSIS 3.5 starting July 1st. That means that the agency is responsible to make sure that their EPCR vendor is up to 3.5. Otherwise, the PCRs will get uploaded to the state, and you'll be non-compliant with state regulation, and then the state can censure you for it. So it's not the PCR vendor obligation to be compliant, it's the agency's requirement to be compliant with NEMSIS 3.5. And they have to make sure that their vendor is compliant. If they're, it's not going to fall on the vendor, but the agency. Let's see. There was a discussion about blood regulations. They're trying to move the blood not only from, right now it's approved that air medical transport can carry blood for pre-hospital use. They're trying to speak to Wadsworth about getting it into ground ambulances so they can carry blood for trauma. There's also actually NHTSA and I guess the federal agency of EMS is also having a discussion, and they're accepting information on pre-hospital blood transfusions now. There's an open link on their website for you to post comments. There's this guy named Don Hudson who keeps talking at the state meetings. So we'll let him again give his report. And then one other thing was New York City, updated their, tactical medical protocols, which were approved, and that's really all this, the New York State CMAC stuff, aside from training and education, which shall be for Don. Are there any questions on the New York State CMAC? No, okay.
Dave, the rollout of the new protocols was July 1st.
Yeah, the protocols, the version 23 go away at 11:59 and 59 seconds, and then the 24 come into play at 0000.01.
Do they have an online training like they did in the past, or is it just to the individual medical directors?
I believe there was an online training. No.
They're not.
So the feeling is,
Last time they did that, that's what I'm asking.
yeah, the feeling of the med standards was with the change log, there was really no
So it's
substantive
up about
changes.
There's a
Yeah.
change,
Okay.
there's a change.
I
log
just,
on
I
that.
just wanted to know so that way we could
Thank you, Don.
educate.
Yeah.
Thank you.
So, yeah, there's a document that goes with the protocols that shows you the changes. There's really not a lot of substantive changes. So I think that's probably why they didn't do the video then.
Yeah.
Yeah, I think it's 24 -02.
Oh, it's
The updated
I mean, it's a advisory, got it.
01 and 02 for BLS and ALS.
Okay, cool, thanks.
Okay, so that was CMAC. Moving on, given no questions for the state, QAQI, Dr. Zazo.
Hi, good afternoon, everybody. I just want to thank everybody who came. We just had our, today, right before this meeting, we had our first in-person QAQI. Several cases were discussed with remediation, a lot of airway issues. I'll just leave it at that, make sure that if we're intubating, that we're filling out the intubation form, and that we use end-tidal CO2 on every patient that we tube. Also, the biggest thing is we're gonna be coming out with forms, standardized forms for an issue forms. So if that comes out and you have an issue with anybody in your department or a complaint you need to bring to us, you'll have a form, and then we'll also have the resolution form, so to speak, where, okay, you talked to us, we discussed, and what did you do as the agency medical director to remediate that situation that you'll send back to us? So we try to make things as easy as possible. Just a reminder that the only two pediatric trauma centers right now in the region are LIJ and Good Sam. All right, if you have a pediatric trauma by criteria, no matter what the hemming and hawing is, if they meet criteria, they need to go to one of those two institutions based on where you're gonna fall in the county geographically. Okay, what's more expeditious, all right? Going to alternate hospitals that are not pediatric trauma centers are not appropriate. So we just wanna make sure we can fix that. But other than that, we'll have another, that will be next cycle, and we'll further stuff. Questions? Okay, thank you.
All right, nice and fast, thank you. Sort of belies the 1 hour meeting we had just. All right,
We
and
just digest.
so rather than, rather than have to, we have our airway committee chairman, Dr. Newman.
Thanks.
Newman.
All right, let's go. All right, so just a couple of things.
Sorry.
We did not have a airway committee meeting today because the QAQ, we didn't want to conflict with the QAQI committee. Plus, we have a couple of things we're still working on. So we'll be meeting in July, and then we'll report back. When's our next meeting? I guess September? We have one in August?
The next REMAC is in
Yeah.
August.
In August. Okay, so then we're gonna have our meeting in July, and then we're gonna report back to everyone in August. But just a few things on the agenda to talk to everyone about. The first is that, just to reiterate what Dr. Zazo was saying, there's been some feedback coming direct to me about the airway form on eBridge. It's really important for everyone to understand it's a quality assurance tool. It is not meant in any other way. And, we are pushing lots of things forward in the county, especially RSI and a lot of other things where we're trying to be progressive. And the only way to be progressive is to monitor what we're doing and make sure we have the right data. It would be remiss of us to be pushing RSI if there was some kind of issue with just, routine daily intubations that we were missing. You would not want to be pushing to be up here if we were missing something down here. So that's the impetus as to why the airway committee, and this was the committee decision that we need to go back to having that form so that way we're getting the data. The other statement that's been said to me is, well, why don't you just review the PCRs? We're not going to review every agency's PCRs. A, you wouldn't want to do that for QA reason unless there was a reason to. B, this then allows us to screen it. If the form is fine and there's no problems, then we know we're doing a good job. If there's something that comes up on the form that we need to look into, by all means, we would then reach out and look into it. But it's not meant to be that in depth. It's meant to be kind of a 1,000-foot view to make sure that everything's being done properly. It was the standard in Nassau County. Does anyone know when we stopped doing that? Because it was originally the standard here.
Yes, it was.
A while ago.
a while ago. So it was originally the standard here.
Stop having to submit those forms here.
We've had at least 10, maybe 15 years ago.
So it was originally the standard here. It's been the standard in Suffolk County forever, for eons. So if you go to our friends to the east, they have to call medical control and they have to go through a whole debrief when they intubate somebody. Well, clearly we didn't want to go into that in depth. But this was the most reasonable and fair way to make sure that we're providing quality care. And that's what's important for everyone. So just, if there were questions about the rollout, please reach out to us with, Don, myself. These guys, we're more than happy to help if anyone's having issues with that, but it's just meant to be a quality issue and we got to be sure we're doing the right thing.
Right, and it's a regional standard.
It's a mandate.
The
Yeah.
mandate, we have to do
Right,
it.
but the mandate's to make sure that we can stay a progressive system. So
Right, no, no,
that's
but it's
the
not,
idea.
but just to reinforce, it is not optional.
Right.
So if you're gonna do it, it's not, again, it's not because we're trying to be punitive or, again, it's to get quality data for good patient outcomes, see if we need to fix something, that's all.
And then we're still working on the difficult airway course. That was been the limiting factor into getting more people enrolled. We're working with FPA, and we should be able to, talk about that more at our July meeting. And then, from the iGel side, I had two things. One, New Hyde Park, gave me an application to do BLS iGel. Under new business, I'll just ask, it has to go to the airway committee, but because we went backwards, I just, so we can move forward, I'll just ask that everyone, as long as the airways committee is okay with it, if we can move forward with that. So I'll put that in new business. And then, I had an inquiry from an agency that was doing iGel, about can BLS providers do end tidal capnography? 2307 defines the scope. It's a bureau policy. That is not in the scope for BLS providers. However, if they are enrolled in the pilot, they are allowed to do it as part of the pilot. So, yes, correct. But that was the question, is where did it fall in the scope? So because it's a pilot program, the EMT is part of the pilot program, are allowed to do it because it's mandatory as part of the pilot program to make sure they're placing the airway correctly. Any other EMT, until they make this a standing order policy, cannot do end tidal. That is outside of the scope if you're not involved in the pilot. So that was a question that was posed, and I wanted to be sure we had it on the record so there would be no confusion on that. So, good. So the answer is then, get your agency involved in the iGel pilots, and then, then we'll be able to push things forward like we're doing. So I think that's the good answer to that. Any other questions? A couple of people in the airway committee, I think that pretty much covers what we've been doing. Any questions from the group? Back to you, Trevor.
Great. I'm just gonna leave my notes here.
So next committee is protocols. Dr. Ryan,
He has to be excused. There's no
Okay.
protocol pending.
okay. Is it has to be excused?
He just sent an email.
All right, so, just remember protocols are changing, July 1st. Credential Subcommittee, under new business, we have a request for a field physician. So Dr. Kirshen will bring that up under new business. Otherwise, I have no other new business or any reports. Policy Subcommittee, Doctors Bramante and Dishner are both excused from the meeting. I don't think we have any pending policies, given the fact we just updated the airway policy. RTAC, do we have any?
So the RTAC met, last week virtually. They too are still trying to reorganize. So, they were made aware of the original program agency and the deliverable to support RTAC. They're going to look at what that might mean for them moving forward and, let us know. So the only two things, we discussed, which came out of some of the other meetings that we'll mention, in regards to cricket, the regional, New York Blood Center was made aware, which sort of fell through the cracks initially, but the, New York Blood Center was made aware, as was all our trauma centers for, sorry about the radio in the background, the potential need for more blood in the event of a large scale incident. Asking the trauma centers and RTAC, if one or two massive transfusion protocols are implemented, it strains the blood supply. So, if we had a number of patients that exceeded that, it would be a regional event. So that was some good things. And then it was also placed on their radar, the continued ask or the continued evaluation of whether the region should be using tranexamic acid. Previous RTAC felt no. I think most of REMAC is in agreement. It's not appropriate for our region with short transports. But if that changes, that's what we want this interaction to be, so.
Okay. Will they have somebody coming to our meeting?
They literally just figured out who will be the chairperson of the committee. There was some wranglings about vice and secretary. I think they will eventually get to an RTAC rep for REMAC.
Okay.
Go. It was asked, it was put on their radar. They are a little disorganized still.
Is anybody still
only been 5 years.
using tranexamic acid in trauma? So
So,
we're using a couple of our facilities for maternal hemorrhage as part of the protocol, for maternal hemorrhage, 1,000 IV piggyback.
No, the question was from an EMS perspective, whether the EMS.
If anybody's using it in their hospitals right now.
yeah, it's in the maternal hemorrhage algorithm.
Yeah.
But, with regards to EMS, the state regulations say it's up to the RTAC, it's up to the region
Mhm.
to implement, and our region has chosen to defer to the trauma specialists. And the trauma specialists have said, no, we're not gonna carry it in our,
Yeah, we're not using it either.
So-
You're not, okay.
Only maternity.
I mean, you have to do elastomeric testing to see if it's actually gonna be effective.
I just
And that's not it's not really a test that everybody does off the cuff with their VBG and trauma, get a stat criticism. All right, so, any other questions about RTAC for Don?
So just to that, they
Yeah.
were struggling too to sort of find their way in the world. What are they supposed to be doing? Why is EMS here? We all know ACS beats us up for lack of EMS integration, but we still don't know how to talk to these ambulance people. All of that, you know, was in its infancy still
Okay,
as they relaunch. So, you know, obviously, all the trauma centers are represented there. It seems like a perfect clearinghouse for all those things that we all know we're required and want to do well. It's just in its infancy.
all right, so, eBridge,
Oh, Comtag, so I'll defer back to Don Hudson since you have the floor on the eBridge updates.
Yeah, so the updates went live the first. It's still a phasing in process. So, you know, aside from the usual feedback of, you know, it's too much, I don't have time, why now, why me? All those other things that we know, we'll just have to get through the training and experience. It's been implemented, the feedback from, agencies that have embraced it and providers that are utilizing it, along with the physicians, at both medical control and the receiving hospitals is phenomenal. Particularly, it was mentioned at RTAC specifically that being able to have a glimpse, meaning a picture, if not a live streaming video of what trauma patients look like before they get to the hospital is game changing for them. So gone are the days where they have to guess how bad it sounds, whether it's low ball, just somebody who's making more of it than it is, or worse, they don't want to get it wrong and say, you know, boy who cried wolf, we'll see when they get here. It really is speeding things along. So we'll continue to monitor and push it forward.
On which sites are you using the camera? We haven't installed a camera.
For the EMS units, so it's up to the hospital again, you know, not to speak for you.
right, so the EMS agency, whether they use a tablet or they use their PC or they use their iPhone to access eBridge, most of those devices have cameras and they can transmit an image from the scene. They could, one of the very first uses we had of eBridge was of an RMA sent to medical patrol where they actually videoed the patient. And the doctor was actually able to talk to the patient and see the patient and say, yeah, I agree, even though you have a head injury, it was probably from your seizure. And the patient was a clinician who was cogent enough to articulate his need to not want to go to the hospital. And with the ability to visualize the patient, it worked out well. Everybody was happy. The patient was happy because he wasn't forced to go to the hospital. The medical control physician doing the RMA was happy because he was able to do a face-to-face with the patient. So it does exist, but there are some limitations. For example, when you're using your tough book, tough books don't transmit ETA data. You have to manually put it in. If you don't put it in, you're not going to get it. Sometimes you don't get the Wi-Fi connection from the front of the vehicle to the back of the vehicle is what I was hearing from some units. But for the most part, you should be able to receive visual communication from the field to the hospital and to medical control. If your hospital doesn't have a camera and a microphone set up, then you could type in questions to the unit. But the guiding premise behind having the audible and visual communication is so that the provider, who may be by themselves with the patient in the back of the ambulance, can put the device down and can have a conversation with the physician. And the physician can see and talk to the provider and see the patient while the provider's taking care of the patient and not worrying about holding the thing and doing whatever. They can have their hands free to do the primary mission, which is take care of the patient that's with them. So when we type in messages, our providers in the ambulances may not get them right away because they're busy. So
Are there hospitals that currently have the microphone and the camera installed?
Yes.
almost all of them.
Yeah.
Maybe comments.
Yeah,
I wanted to make a statement that I think it's important to recognize that eBridge, while it has some excellent advantages, has become increasingly complex. And while I do hear there are reports from the hospitals and the agencies that they love it, the physicians love it, what I need you to know is it's not that universal, and I'll explain. The other day you received a cardiac arrest patient. Did you get an eBridge notification for that patient, Doc?
no, and I asked the provider
I
why,
apologize. I was involved with the assignment. I just wanted you to know why.
but I asked the provider, he explained to me that it was difficult for the
Thank you.
the communications software and apparatus he has in his vehicle. His tablet couldn't communicate with the Wi-Fi equipment in the front of the vehicle, so that he wasn't able to transmit an eBridge notification. And it made sense that there's equipment limitations in some ambulances that need to be modified. But those are agency expenses, and I get it.
Doc, let's leave out the technology. The complexity with that patient presented negates the ability for those individuals treating that patient to be able to type on a tablet.
So that's a conversation for another time.
I just wanted to let you know that-
eBridge has been in place for over a year.
I'm not suggesting that we get rid of anything we're doing. I
Right.
just want to revisit the increasing complexity.
So, all right, so again, if you'd like, I could show you how easy it is after the meeting. But,
Thank you.
all right, so I understand that there are some issues. Is there any other issue with the bridge or any other concerns? Yeah,
It's just a question.
Yeah.
We've had it in place for over a year. What's our penetration? What's our percentage of agencies actually using it?
I would say based on the volume of calls that I assume that we do per year versus the amount of notifications that go through eBridge is probably about 50%.
50%?
But
So,
it's not enough.
let me, other than
It's an estimate.
the last week because of cricket and other issues, so that's posted weekly in the MS coordinators report, is eBridge usage for the last 90 days. Basically for a 90-day period, it's in the tens of thousands of uses.
Right.
So it's been well embraced. There are still agencies and providers that are holding out. This is one of the reasons why the REMAC and REMSCO saw fit to put in my opinion, properly so, the requirement for it to be tracked now by medical control and a monthly report issued to the QA committee for non-compliance. And if it's a patient complexity issue, that should be the one-off, not the norm. If there's technology issues, those should be reported to the region and to the council so that we can work with them. There's funding available for new technologies and grants. But we can't fix problems that we don't know about.
Now, I see the report each week. It shows the number of eBridge
Right.
usage. It doesn't show how many calls it were versus the number of eBridge.
We're trying to
That was why I had the question.
part of why we have eBridge historically, right, we're trying to build a system. We haven't had a system in
No, it's
40 and
perfect.
50 years.
I embrace it.
So we're baby stepping this. Now we have the ability to see PCRs when they get uploaded. We have the ability to now track hospital calls. using a sophisticated database and data tracking. We're trying to put all the pieces together. But, you know, there are some impediments and everything is taking time. But it's slowly coming.
I just want to make a comment, and I know it can be complicated out there, but it has made a world of difference already in hospitals.
Right.
I can tell you, just even working a clinical shift like yesterday, I had maybe 2 or 3 patients that did not come in through eBridge there. And I know it's a change, just like we have to deal with in the hospital, but this will take care of our patients better. It will. When we start to get a STEMI alert that comes in through eBridge and I activate the cath lab and it's 6 o'clock and I would have waited, or that patient would have waited 45 minutes for the team to be there, and now it's only 20 minutes, that's a life saved. When we get a call for a stroke that somebody gives me through there and I activate that, and it is a large vessel occlusion that I can get at, that's a patient saved. And when we talk about trauma, this is where we're going with technology. It is great. You know, I know that you guys worked hard on this for a year. It is working and will continue to work. And it takes change. And there's gonna be times where it's gonna be tough and you're not gonna be able to do it. But I think overall for our patients are gonna do better.
Just one second, yeah.
I work in Medcom a lot, as you know. Do you think that maybe through this body and to the medical directors, we could revisit pushing it out, that this is actually a mandate from here?
Yeah.
Because there are several agencies, I can tell you, and I will not name people, and the same voices over and over again. I've been told over the radio, we don't use that yet, we don't participate in that. Obviously, I'm not gonna get in a fight over the radio or the phone with anyone.
Right.
And these are big agencies that they cover a lot
Yeah,
of
that was,
volume.
that was addressed,
So I think that.
privately at the QA committee as well.
But it's also, it's not proprietary agencies, it's also the ones that are out there voluntarily doing it. So, I mean, definitely, we're missing, and that's what I tried to, I got a phone call last week. I don't understand why you told me that. I said, we're trying to capture data and take a snapshot of what's going on. And your agency accounts for 3,000 EMS calls a year. We need the data. And I hope that you guys can, you know.
No, agreed. And so there is a state regulation that requires agencies to participate in regional quality.
Yep.
And this is a regional quality initiative that we've taken up. And so failure to comply with this regional quality initiative makes your agency non-compliant with that state regulation. And ultimately, what's going to happen is we're going to enforce it through the state. It's not gonna, it'll leave this body.
Yeah.
I
would hate to see it get there, but I
Right,
understand
right.
exactly what you're saying.
You know, we're all volunteers here. We've been disempowered by the region's elected leadership. And so we're doing things that we can using state regulations to enforce good medicine and make sure that the people that we're responsible for caring for get the best quality patient care that they used to get 30, 40 years ago, when this region was the #1 region in the country. You know, we're trying to get back to that. So we're #1 again. Yes, Alan.
It's been a year. Why don't we just set a sunset date? 6 months, you either use it or we do enforcement, and that's it.
The problem is, I spoke to Ryan Greenberg. The state's not willing to help us with that enforcement unless we go the quality route. And then going the quality route is very difficult. And that question I posed to the state 8 months ago, 9 months ago. You know, this is not something that has been soft. It's been something that I've been pushing very hard for up at the state level and locally, agency by agency. But with the amount of pushback and then the lack of effort or enthusiasm on the state level, it falls back on us, but we have no teeth, so then we have to go to this regulation where we don't want to have to pull the you know, pin on a grenade. We'd rather just like use our ink and pen and write something and get something done and work together. But people seem to want us to have to pull that pin instead. You know, I'd rather, you know, get more bees with honey, so try. But how do you propose to, I'm sorry.
Let me just comment on that. I think this, you know, Alan, to your point, this has been, since we started to talk about this well over a year ago, the issue was gonna be the compliance issue. And so when there's a mass amount of change, I think collaboration is the way to go. you don't want to hit people with a stick. The carrot is always the better approach.
How long you gonna wait?
We've gotten some really good traction, tens of thousands using it per month. It's not as if it's not getting utilized. Change takes time, and this is a very complex region. We'll just leave it there. And so change takes time. And I think that, I applaud everybody and I applaud the comments of embracing technology. That change is difficult.
It's complex because we don't have a system.
Right.
We've got, what is it, 80 agencies that pretty much do whatever the hell they want.
So how, if you were to put on your,
The REMSCO has the
Your fire
authority,
chief
REMSCO has the authority to determine how EMS will operate in a given region.
okay,
They need to do that. This is very simple. Suffolk County took some big steps 15, 20 years ago. A lot of agencies took them to court and they lost. Sometimes people need a kick in the butt.
the one difference though is Suffolk County, they had the backing of a governmental agency, Department of Health. We asked our Department of Health for support, and they weren't able to provide the bandwidth to help us. Their medical director in Suffolk County is actually an employee of the Suffolk County Department.
Yeah.
I get paid zero.
I know.
I don't work for anybody. I work for Northwell as an ER doc. And as a associate medical director for doing quality education.
I've been in the system for 40 years.
Yeah, right. It,
Hasn't changed.
sorry. So we're going to work on it little by little. But if you can conceive of a great way to sort of light a fire under people's butts and get them to utilize the service, the e-bridge, which is free for our EMS agency. Right, that's the other thing we did for everybody. You got the hospitals to pay for it.
Yeah.
So there's really no financial excuse. If you can come up with a means or way, looking at the regulations, I would formally embrace anything that you gave to us into this body. So we could sort of push.
I think if I can just jump in.
Go ahead, Tom.
So in talking to leadership, REMAC and REMSCO, the intent of the reporting from medical control is to find the root of the problem. The speculation is that until we get through the probably somewhat still, although admittedly embarrassingly possible, is I didn't know.
It's not.
We'll fix that. We don't have the tablet. We'll fix that. It doesn't connect to our Wi-Fi. We'll fix that. Eventually, I agree, Doc. We're gonna find the person that said, or the agency that says, I'm not going to. We saw it with controlled substances from our region. We saw it with EPCR from our region. Let's not, be naive and think it won't come to that. I think that is the very small minority. And until we get through everything else, which admittedly may take a frustratingly longer period of time than any of us would have hoped. But this is what we signed up for and we'll get through it together.
So Doc, I just wanted to say, my question wasn't against it, and I thank you for all you've done. As a provider using it, and in my agencies, one of which is an early adopter, it's been working wonderfully for us. And for me personally, as a provider, it's been working really, really well. My only question, the original question, I was just curious of what the penetration did. That's all it was.
No, I
So
understand.
it's really, I'm, as a provider, I want to tell you that I personally think it's great. So, thank you
Dave, then-
for all you've done.
Yeah, thank you.
So as an old dog trying to learn new tricks, and as a professional and volunteer, not that volunteers aren't professional, there's a learning curve. Any skill that anybody in this room has, you didn't pick it up just like that. And e-bridge is a skill. And the more we use it, the better we're gonna get at it. And yes, there are patients that are too critical out in the field that may prevent us from literally typing into the tablet. But for the most part, high percentage of them in the 90s, we can do it. It just, we need to start learning how to use the devices that are at our fingertips. And that's all I want to say.
No, I just wanted to echo what he just said. When you look back 7, 8 years ago and stuff, we were in free fall. We had no credentialing and stuff of ALS providers. We had no idea who was working in the region, who wasn't working in the region. And we've gone leaps and bounds and stuff during the past 50 years, so. The last 7 years, once again, have flown by. We've done so many things that, once again, we never even thought about 10, 12 years ago. It's true, once again, as far as, it was designed for quality improvement and once again, for awareness for our QA people and for the system-wide, assessment of the system. Once again, be able to bring in that information. Hopefully in the next few weeks, as you know, Part V fell out of the regulatory, the executive budget once again, and had a lot of regulatory things that would have helped us in assisting and getting some of that information. But now, once again, hopefully these bills will pass, central services and other things, through the state, SEMSCO and CMAC. Once again, we'll see, increased data on a monthly basis from agencies required by the state to be able to bring that information to us, because as you said, we have 80 agencies out there. If they feel like sending us the information, they will. If they don't, once again, there's no way for us to drag. We've been working through the back doors and through, once again, different agencies and organizations and stuff to try and get these things tied up, RTAC and all of the various things through the county. We have this report that's gonna come out. Hopefully we'll reconvene during the summer to look at the recommendations. It's been 18 months sitting in meetings and stuff, going over it. You know, the bottom line is, you know, it's a lot of time, but we've come a long way in the past 5, 6, 7 years from where we were. And we're gonna keep at it. The ball is moving in the right direction once again, and we're going to continue to push our legislative people, our county administration, getting more input and stuff from various organizations, as we said, through the state, local, and hopefully, once again, we'll be able to open those doors and once again, gather that data so that we can put it all together. Because with duplication of calls, it's just killing our service. We're killing ourselves.
Yeah, just one quick thing to end it as well. As one of the providers mentioned earlier, maybe one of the ways we can entice the buy-in from the agencies is showing those and applauding those situations where we had a decreased door to needle time because of eBridge. We had a decreased time for a patient to arrive on a table to open up those arteries and have a positive outcome. And maybe pushing that to the agencies to make it a situation of why not you as a provider? Why not you as an agency? Similar to how we adopted American Heart Association standards, and we realized how that chain of survival was so crucial and how each part of it made it end, and make this part of that chain of survival is that early notification being through eBridge.
Just one quick clarification before we jump on, just for informational purposes, Suffolk County EMS is legislatively under the DOH in Suffolk. I'm on the Board of Health here in Nassau. It is not legislatively assigned to us. That's why not that we don't have bandwidth, but it's just that we don't have the legal authority to take it under.
Signed by the state to the Department of Health?
What's that?
Article 30.
It's
Article
30. Oh, okay.
There's a special Suffolk section
Yeah, Suffolk's out there on.
back to, as the good doctor was alluding to many years ago, when their system was in very dire straits and needed legislative change to fix it, so.
All right, thank you. All right, that was great discussion about eBridge. I appreciate everybody's input. Just moving on. Nassau EMS modernization redesign tag, Dr. Newbert, I think there was a document that was put out.
Yeah, the county report has been put up on the REMSCO website. Came back, I think it's 400 some odd pages. There is at some point in the near future a scheduled reconvening of the committee that was all encompassing from all different agencies throughout the county. And hopefully, once again, some of the recommendations that are in there can be adopted and we can start moving forward to put them into play. So hopefully, and once the cricket tournament is over, there's supposed to be a meeting regarding that. And then once again, we can look at how that plays out, as well as once again, how these bills in the next week or so play out in the state legislature and the Senate as far as EMS reform on the state level.
I just have two quick addendums from my other one. He just gave that. The reason that the question came up about N-Title and iGel was because there's a specific company that makes a CPAP brand that says they recommend you use it with N-Title. Clearly, state DOH regulations precede a company's suggestion. That's why that's why that question was there. That's the context of why I got the question about the N-Title and BLS providers, because BLS is using CPAP but wouldn't be using N-Title. There's no issue with that. You're following state regulations.
Does that same company make their own entitle?
Probably. And probably. And the question came up during QA, and I forgot to mention this, what to do with the airway form. If there's a termination at the scene, then you just have to make sure you attach your N-Title CO2, which is the standard for everything. So. And that's an after the fact, by the way. No one should be doing the airway form while intubating the patient. That doesn't make sense.
Yeah.
It just- Kate doesn't clarify that. Yeah, you can't have to clarify that. Got it, click. Please don't do that. Please don't do that. Yeah, please don't do that.
There's a hole in the form.
Yeah, you're right through it.
Or so the ME can look at it, right? All right, so, moving on, Chairman Mackey from Remsco.
Oh, okay. Thank you, Dr. Coolin. Well, first of all, I'd like to thank Chairman Chester from the awards committee and stuff for sitting down and convening a meeting of the public education and awards and coming up with the award recipients for 2023. We had 9 recipients. We're working on, once again, an EMS dinner, probably in the fall, once again, to commemorate their work. The award winners for 2023, Advanced Life Support Provider, Michael Mena from Northwell Center of EMS. The EMS Communication Specialist of the Year, Megan Allison, also from Northwell Center for EMS. The Harriet C. Weber EMS Leadership Award went to Mark Vitale, Nassau County Police Department Air Bureau, as well as Seacliff Fire Department. We had 2 Educators of the Year awards, Joshua Golub from the Nassau County EMS Academy, as well as George Choi from the Nassau County Fire Police EMS Academy. The Registered Professional Nurse of Excellence went to Kristen Keating, North Shore University Hospital in Manhasset. The EMS Agency of the Year was Northwell Center for EMS. The Costas T. Lambrou, MD, Physician of the Year Award went to Jatinder Singh from Nassau University Medical Center. And last but not least, the Nassau County Remsco Chairman's Award for 2023 goes to Kevin J. O'Hara, once again from North Merrick Fire Department, as well as a educator from Nassau County EMS Academy, as well as the Fire Police EMS Academy, who has completed 50 years of EMS service here in the Nassau County region, and is vital to many different associations and once again, the council as a whole with that. Once again, as you mentioned earlier, the pre-hospital pediatric readiness project, I want to thank Dr. Matthew Harris for taking that on and getting that out. Once again, making sure that once again, we get our agencies to complete the forms, as well as also selecting PEC coordinators within their agency to look to educate their providers on pediatric emergencies. I'm currently working with the Fire Commission. I've contacted their chairman to work on an EMS memorial for Nassau County to be combined as a first responder memorial at Eisenhower Park, as they have to once again rebuild theirs. The thought process was fire and EMS going together as a first responder. We could once again collaborate on a design to be able to do that within that. We have the space over there and we have the approval. We just need to get a design, and I'm hopeful to have a meeting in the next month or two with a architect to be able to put that together and bring it for funding as well as for adoption by the county with that. The council bylaws, the legislative committee is currently looking at all bylaws through the summer. to bring back for any amendments as well as any, for adoption at the September twenty twenty-four meeting. So they are currently working on that. The membership committee, is reviewing, council attendance for all meetings, as is stated in the bylaws and stuff. We have some areas where we have, constituencies that are not being represented. And, they're gonna bring back a report at the next, meeting with that. And then last but not least, the, next REMSCO meeting will be on Wednesday, June twenty-sixth at 1400 hours here at the Public, Safety Center. Actually, one other thing, the regional council, in coordination with the, disaster preparedness and MCI committee, it will be holding a training session for leadership as well as for training officers in all agencies, at the, Borelli Homeland, Security Center on Thursday, June 27th at 1900 hours. So once again, please get to your agencies and, anybody who is interested, we're gonna be rolling out the training, for agencies to, adopt, to once again start the training on the, regional policy, that exists. And once again, you can find that also on the website. And that is all I have today.
All right. So
Any questions?
our preeminent Nassau County EMS coordinator extraordinaire.
So the topic of the month is the T20 cricket. So we've met, as I said, we mentioned RTAC before. Also met with, all the hospitals, either executive leadership, medical leadership, or emergency preparedness through the Health Emergency Preparedness Coalition on New York State Department of Health level, both virtually and in person, trying to answer their questions with cricket. We've also been hosting for partner agencies Wednesday night, virtual webinars. Those are forward-facing, so fire and EMS agencies, related to the event. So specific to the event, the region, in conjunction with New York State EMS, New York State Dishes, and New York State Health, is tracking some metrics daily. So 6-1 was the first exhibition game. That was Saturday. There were approximately 7,000 attendees. Average ambient temperature at noon was 79 degrees, 32% humidity, 26 total patients, 5 transports. 6-3, the first official game, approximately 16,000 in attendance, 82 degrees ambient, 42% humidity at noon, 45 total patients, 6 total transports, most of them heat related. The game ended not too long ago today, so we're waiting on today's numbers, but you'll see these posted in the EMS coordinators report as well as daily reporting to those partner agencies. Other than that, yeah, it's been consuming most of the time right now, so.
Thank you for keeping us up to date and informed and working with all the partner agencies.
Trying to do what we can.
Representing EMS in the house of this disaster.
Yeah, while you're on cricket, once again, on behalf of the council, I want to really, thank, Northwell Center for EMS, NYU, EMS, as well as, GMR, and some of our volunteer ambulance corps and stuff that came out and are providing standbys daily, for the agencies that are directly involved in this over at Eisenhower Park. Like I said, our Achilles heel, unfortunately, is daytime, status of our units. And, very difficult to get them to stand by for 8 to 10 hours. So I can understand, some of that, but, our main concern was making sure that not only was the event covered effectively, but that also we cover the county during those 12 days, for all of the residents and the visitors, to the county. So I want to thank all of those agencies that stepped up and took, the initiative to once again help us out, with that. So thank you very much.
Thank you. So, anybody from the fire marshal's office? At the hot wash. Okay, yeah, so cricket is the flavor of the day.
So unfinished business, there's no other E-Bridge updates. Any other old business? Okay, under new business, we just have two items, and then we have a presentation from Live On New York. First item is approval of Dr. Neil Kirshen, who's REMAC member for the position of Nassau County Field Physician for the Rockville Center Fire Department. And his second. Okay. Anybody abstain or oppose? Okay, and then Williston Park submitted necessary state and regional documentation to change their medical director from Dr. Ing to Dr. Zito. Dr. Zito is already a regionally approved agency medical director. It's just a pro forma approval by this body. I just need a motion to approve. Dr. Shearson. A second. Any abstentions? Any disapprovals? Okay, great. So that's moved. All right.
And then Dave, I just need the New Hyde Park for the iGel, as long as the airway committee approves it next month. For BLS iGel.
So, yeah, they need to get the paperwork to the region too. So
Yeah, I have it. I got the paper. It's just, I would have done it at the airway committee, but we postponed it, so that's why I was my first.
All right, so what your motion is to approve New Hyde Park BLS iGel.
As long as the airway committee approves it in July.
Any second on the motion? Dr. Shearson?
Thank you.
Any abstains? Any noes, nays? Okay, motion passes. Everything passed, which is great. So before we adjourn, we're done with our formal business. We're gonna have a presentation by Live On New York. So, if you guys have to run, thank you for coming. For those of you who can stay, please do so we can all learn about the organ donation here on Long Island. I don't know what that is. Everyone just relax. Is that you?
Definitely not me.
I guess it could be less embarrassing.
Wait, is that fair? No. The fact that I remember that is really sad.
Thank you. Thanks for coming. I'm glad you finally interesting.
Yeah.
Oh,
Yeah, it was actually.
no.
I'll be quick. I know it, exactly.
I have no idea. I don't know where that's coming. I sit over here, so I can check. Yeah, I would run away too. Oh, yeah. That clicks, I don't know.
Right, I was gonna say,
It's gonna come back on, stand by.
what else are we gonna play from the
I don't
seventies?
know. Sorry.
Karen Valentine, maybe?
I mean, Live TV,
Whatever night all men would come around. I like Sarah, but. Never had to tell me well.
Oh, thank you.
3 months of hell to get in trouble. I haven't been here. I know I think it'll.
Okay, I'll talk without it, and that'll make it even quicker, right? So I'm Karen Cummings, I'm the Senior Manager of Community and Government Affairs for Live On New York. And if you don't know who Live On New York is, Live On New York is the organ procurement organization that handles the New York region. And we handle everything from the tip of Long Island to the lower Hudson Valley. So about 70% of the state is managed by Live On New York. We're the second largest in the country. We oversee an area of over 13 million people. And we facilitate all the life-saving transplants in the area. So you could go to a transplant center if you're in need of an organ donation, but we're the ones that actually get the organs to give to the patients. And we're really here kind of trying to spread the word on how important organ donation is. You probably are not involved with organ donation cases in your day-to-day work, but we wanted just to let you know what the status of organ donation is in our area, and just so that you are aware of the process. About 10,000 people are currently waiting for life-saving transplants in our area. About 70% of those that are waiting just for kidney transplants.
You say in our area, do you mean Long Island or Long Island, New York City?
Long Island, New York City. But it actually kind of goes in place in Nassau County also. Nassau County probably has about 3,000 people that are waiting. And that's the largest need. On average, most people are gonna wait for a kidney transplant in our area between 5.5 and 7 years.
Wow.
So even though we have a large portion of the national list in our specific area that are waiting, we are the least state to donate. Which means that if you needed a transplant in our area, you're gonna wait twice as long as every other state in the country. So, yes,
Just a quick question. So you said region. So if you, let's say somebody needs a kidney transplant, what region do they have to get it from? Can't they get it from Kentucky? I mean, like, how does that work?
well, you can't get it from Kentucky because when you list yourself, you have to be within 2 hours of that
That's the
location.
limitation, right?
Yes.
You can't.
So ideally you could, right? But the call could be like on Friday at 5 PM.
Yeah.
How would you potentially get to it?
Right.
That's the difficulty, right? Because most states are way above New York. Most states have over 60% of their residents that are registered. Some states have over 80%. New York has about 44%. So people in our area wait a long time for a transplant. So our goal is education and awareness. A lot of people are gonna sign up when they go to the DMV, which is usually a primary place where people register. And it's a law that any license transaction, whether you're getting your license for the first time or renewing it, they're gonna ask you the question. But you can do it through New York State Health Insurance, you can do it through voter registration. There's a lot of ways in New York State that you can actually register, but New Yorkers are unfortunately not doing it. So most of what our job is, when a patient dies in the hospital, we are notified of every death. So on average, we get about 60,000 calls per year. Then we have to check and see if that individual has already expressed their wishes to be an organ donor. If they haven't, and most people in our area have not, we have to go to their next of kin or their healthcare proxy to ask them for consent. About half the people we approach say no, not because they don't believe in donation, but it's the worst time to have that discussion with someone. So our goal is to be proactive and have that discussion and education beforehand, so that when they're approached in the hospital, the families are aware of what their loved ones' wishes are. The good thing is that we are on the upswing. In the last 2 years, we've seen an increase of more than 50% of the numbers of lives saved, of the numbers of donors, and the numbers of transplanted organs. So we're going in the right direction, but there's still a long way to go. And because we have so many people in our area that are of need, we're still working on it every single day. So our mission is not just to save the lives of the people that are in need, but it's also to support the donor families that give the gift of life. So most of our staff, which is over 300, are clinical. They're working at the hospitals with patients and with hospital staff making donation happen. But we also have a department that's goal is to support those donor families after that donation with grief counseling and support for as long as that family may need it. So that's kind of where we are for organ donation in our area. Are there any questions?
What can EMS really do to help us?
Well, just so you know, we really follow up on every potential case, and there's not much that is an initial restriction for us, even age. We actually just a couple of weeks ago had our oldest donor, and they were 94 years old, and they were able to donate a liver and a pancreas, actually. So I think what we just like you to do is just be aware of what the process is. So that you understand exactly how it works for us. We usually will be notified within an hour, and it's required by law, that we are notified. And then we're able to try to, talk with their family. We have a very diverse area, whether it's languages or religions, and sometimes people who live here, their family may be in another country, and we have to communicate with them. But what we just wanted you to do is just to be aware of what the process is and who we are. So if you see us in the hospital, you know exactly what we're trying. And that's it. Sorry you weren't able to see the presentation.
That's all right, we were.
Is
I think Cher was more exciting than my presentation was, but
there anything that an EMS provider can do to sort of facilitate this process on behalf of your agency, without sort of saying, we're doing this because you may donate, or
Right.
we don't want to provide, we don't want families to think we're doing this.
right.
So that
Actually, we think it's the worst thing. We want to actually come into the hospital and have that discussion with the family. We don't even want the doctors or the nurses that may have been working with that family over time, really, and built up the best relationship to have the discussion. Because we want that family to have every confidence that everything was done for their loved one. And only after, nothing else could be done within the hospital, that organ donation actually comes into play. We just really want you to be aware of who we are and what we do. Thank you so much for your time.
Thank you very much.
Go ahead.
Is this your meeting? No, that's mine. Yeah, take your.
Yeah,
Is whose clicker? That's my clicker.
thanks for trying.
Yeah. Nice meeting you.
I know exactly. Here in the 70s.
So thank you very much. I'm sorry about that in every way. Right. It's
Thanks
not a
all for
stretch.
having me.
Thanks. All right. Ending the meeting. All right. You have an adjournment?